So, Ashraf, thank you very, very much. And it's really great to be here to see a big audience. It has been suggested that the island is an excellent venue, for should I bore you a little, there's no escape. I want to thank particularly, I can see in the audience, my friends and colleagues, Dr. Channa Jayasena and Wayne Vesey, who have actually done the work in this small pilot study. Quite a lot of work because in the UK, finding patients who may be either refugees from an IVF program or may actually not be entitled to IVF such that we can treat them in other ways is quite difficult. Hard work. But I think times are changing, and I'm going to start off by sharing with you some of the experiences of those changing times in the UK, because I think this applies to all countries, and I think it is mindful for us who concern ourselves with treating infertile couples to acknowledge that the time just may be right to treat these men differently, because they are seeking a diagnosis and they are talking to each other. This is hugely powerful. When doctors just spoke to each other about their patients, around their patients, without including the patients who couldn't speak to their own cohort, then treatment practices just stayed static. But now the patients can talk, then things are beginning to happen. The Men's Health Initiative, both in Europe, in the UK, but particularly in America, I think is really important. People are understanding that the presentation with infertility when you're in your mid-20s and you ought to be in the peak of health may just be beginning to tell everyone that there's something seriously wrong. The metabolic syndrome, premature death, diabetes, all of that is just round the corner for some of these infertile hypogonadal men. In the UK, there's a sea change. This is really, really important. The government, that is the National Health Service England, I'm not going to dwell upon the British government and its other statements too much in this audience. I can only apologize to all of you. But in terms of the health service, then the government has decided that the primary care commissioners can commission for surgical sperm retrieval by micro-TZ. And this is really, really important because today it's non-obstructive azoospermia in the hands of people who will treat the men, that is urologists, and then tomorrow it will be obstructive, and then with any luck, in 5 or 10 years' time, we'll get our hands on all of them. And this is terribly important. Now, we've got to handle this new testing, this wave of increase in DNA testing with great care, because it is both a weapon to result in less investigation, because it's used as an excuse for failed IVF, or let us hope it is used as a tool to investigate and therefore treat the men. But we must be very wary that it is not abused because it should be a force for good. And here's a huge thing. The BBC, Auntie herself has screened a play of the week about an Irishman with azoospermia and the devastating psychological effects on that individual and his partner and the two families involved. You think back, even 3, 4, 5 years ago, the word azoospermia was not in the dictionary of most people, and that it can now be freely used on national and international radio, I think is a huge step forward, and it once again gives us an opportunity for treatment. So what's changed? Well, quite a lot has changed, and here's a picture relating to the various histological patterns that we find when we do a micro-TZ. And this, of course, it has revolutionized the way into treating men, because azoospermia, which was thought to be due to Sertoli cell-only syndrome, 2 or 3 biopsies showing Sertoli cell only, that was the end of the road. But no longer is that the case, because those irreversible diagnoses often coexist with other histological patterns, which not only mean that we have the possibility of retrieving sperm, as you can see from the bar charts on the right side, but it also means that there is a potential for treating the azoospermic man such that he may produce sperm in his ejaculate. This is terribly important, and I believe once again, 5-10 years' time, we will be accepting that some of those men in that Venn diagram on the left are treatable without the need for surgical sperm retrieval. So what about Fna mapping? I believe this to be a revolution because it allows us to guide our surgical microtesi, which is not without its complications. So once again, we are being able to offer men a wide gamut of treatments which are effective, which are considered, and this, of course, leads the way to saying to them, and there may be other treatments too, which can improve your state. Oligospermia, we've been talking about varicocele, we needn't go into it, but the Cochrane review of 2004 was shown to be not as conclusive as it was thought, and that therefore treatment is relevant to these men, embolization, surgical treatment, and the EAU and AUA guidelines have been changed accordingly. This is a big thing. And of course, what does this mean? This means that the man, crikey, do we have to state this? A man with a condition needs to be examined by a physician. But if you're in a fertility unit, not unreasonably, you may not be. So now we have license, as if any license were ever needed, we have license to examine our patients. Crikey. So, here are some important features associated with oligospermia. We've mentioned the metabolic syndrome, the hypogonadal male, and I think the resurgence of hormonal treatment. So we're building a picture in which we can begin to investigate, both by DNA fragmentation and reactive oxygen species measurements. Total antioxidant capacity is TAC. So we're beginning to investigate in every way men, such that this is happening. Men are now being referred to urologists even before they've had a cycle of IVF. Now, does it really matter if it's a urologist? No, it doesn't. To a physician with an interest and the ability to treat. This is a real sea change and something that we must really embrace and develop. And these are just a few comments about the sorts of changes. These are copies of real correspondence in the last year or so between physicians and their patients. I won't bother to read these things out, but each patient tells a story of reduction in DNA fragmentation, reduction in ROS levels, some of them with pregnancies, and again, however do you measure that in a randomized, prospective, controlled way? Jolly difficult, really difficult. But I think all of us who do this feel that time is changing because we can investigate and treat our patients by every single means. And I have a feeling that if we can treat the varicocele, the ROS, use nutrichemicals, banish infection, give nutritional support and advice, each one of those interventions is a little nudge which is getting our patients closer to a natural conception, further away from all kinds of things that may befall them otherwise. The careless surgical sperm retrieval on the basis that the man has a cryptospermia and we need sperm to be frozen before the treatment cycle. I mean, what's all that about? That's for the convenience of the laboratory. It has nothing to do with treating the patient. We need to intervene and change those patients from a difficult or unlikely cycle of IVF ICSI to a place where they can ejaculate sperm of better quality with a better outcome. Difficult to prove, but if you don't try, you'll never succeed. So this business of infection, the ROS levels, high NA DNA fragmentation, I believe, as Ashok has said, and all of us who do it, that we really can make a difference. And what about the issues of nutrition, of men's health, the lifestyle issues, with or without nutrichemicals, but preferably with? These things make a difference. I'm quite clear about that, and the study I'm going to share with you was an attempt to put a number to try to define which patients might be the best for treatment with nutrichemicals. So this is where I think we are now with our oligospermic males. You only have to look around the exhibition in ESHRE contemporaneously to see how there has been an explosion of nutrichemicals. And we may, I think, perhaps have time to talk about the natural consequence of that, which may not just be an improvement in fertility and general health, but we do have to be mindful that patients may assume that even more than is prescribed is better. And there is a syndrome of over-supplementation, of which we should all be aware, but nonetheless, there is a huge uptake here. And this is all despite a rather neutral Cochrane review, as has been alluded to by my colleagues. Perhaps not entirely neutral, because, of course, if you have a look at the numbers, actually, as has already been discussed, this wasn't that negative. So whilst the Cochrane review might have been heralded or interpreted as not being very positive, actually, the review of the review came up with the sort of pregnancy rates that we might expect. And there they are. Not bad, placebo compared with antioxidants. So, all of this has been alluded to, the difficulty of measuring outcome. Pregnancies are best. Natural pregnancies would be even better. But pregnancies by IVF, and there have been some series of those, would be great. Semen analysis, really difficult, but my colleagues, I think, have shown that you can certainly get significant probabilities if you're really careful with semen analysis. But it's not that easy. So, as you probably noticed, I'm the only speaker here without a professorial title. So therefore we've got to keep our studies simple, and we thought, well, could we get a number? Could we get a predictor, a simple thing, which would relate to the efficacy of this case, in this case, using Proxeed? So we thought, well, let's try to measure the reactive oxygen species levels in these patients. These are treatment-naive patients who were examined physically, who specifically did not have a varicocele, who had no clinical urinary tract infection or male accessory gland inflammation. That always amuses me because it could be confused with the three wise men. And of course, those who have magi are anything but wise. And these were trying to conceive for 18 months. So actually, those are quite tight entry criteria. It should be regarded as a pilot study. It has been presented as a poster at ESHRE. And what did we find? So overall, we are finding a little bit of effect on motility, but we're not really reaching significance. And once again, sperm concentration, a bit of a difference. But this could have been that we are concentrating the patient's minds. But now let us look at the ROS measurements. Now those were certainly consistent, and significant. Again, small numbers, but one person measuring the ROS by a chemiluminescence method, the one touched upon by Professor Agarwal, not the new method, as it were, the old method, but measured by an individual who has validated the machinery, and so I think we can take this as being consistent and important. So then if we select those patients who had a baseline reactive oxygen species level above 10, then this is what we see, both in terms of sperm concentration and sperm motility. So it seems, and I stress that this is a pilot study, it seems that the ROS level measured contemporaneously may well be relevant, I'll put that slide back again, may well be relevant to a patient selection of those who may be improved by nutrichemicals such as Proxeed, containing carnitine, and as we've discussed, the other ingredients which seem to have fairly consistent effects in other people's studies. So, in conclusion, I think we've reached a tipping point, a really important point. One doesn't want to overstate this, but if this is an important point in treating male fertility, it's actually rather an important point for fertility. And I think we should go into every aspect, clinical aspect of a patient's condition. We should be making a diagnosis. Why not? We do it in every other branch of medicine. And we should treat them. Every aspect of nutrition, whether it be adding supplements or their own nutritional state, I think is important. And I would urge you all to seize the day. So thanks to Sigma Tau, thanks to Ashraf and the other speakers, and thank you all for listening.